you've heard ligaments is the focus of this session and of the whole day. And we have a meeting in an international sports medicine and knee arthroplasty meeting, and there was Eng who say maybe we should integrate it, ligament balancing in the operative procedure. And I show you how I do that since 6 years, and you know everybody's the bone referenced. So you resect the bone you would replace. And this is the credo of Leo Whiteside, for instance. So he's always say, do the bone cuts very precisely, then put in the trials, and at the end balance the knee a little bit. So the other way around is, this is what I do, you know, I balance the knee first, I plan the prosthesis, I can do it with the navigation, and at the end I do my bone cuts. I just show you the steps of the procedure. So I do first the tibia cut, yes, and then I balance the knee in extension to a neutral position, but I can also do it in 1 or 2 or 3 degrees of varus, whatever you find it is correct. And I have also 80 newtons on both sides. And then I can define the flexion gap, or I can even balance the flexion gap. But it turns out that it's not so necessary to do balance the flexion gap. And I can use 70 newtons on both sides. And then I can plan the prosthesis. I can plan it in terms of rotation. I can plan it in terms of size. I can play around. And I can choose my AP position exactly with the Galileo system I use in 0.5 millimeter steps. So I can really have a very nice flexion gap. And at that point, when I have done all the planning, I perform the dorsal cut, and then I have a special width of the flexion gap, and then I do a synchronization to the extension gap. So I have medial and lateral flexion gap of 70 to 70 newtons, and I increase it to 80 newtons. This turns out to be good, and at that time, if this is all planned and the balancing is done, then I do the cut. So this is the main difference to the credo of maybe of Leo Whiteside and of the bone reference technique. We go on, and the problem is the individual force control gap balancing. What is? We have no really data on the individual patient-related ligament characteristics, and you know there are a lot of individual factors like age, sex, weight, ligament stiffness, activity, patellar position, and so on. And what we like to realize is that we have a real-time registration of the ligament tension. I'll show you what we can do. What we have done is we have a navigated spreader, and so this patient was ready for implantation, and we do a navigation of the flexion gap and the extension gap, as you can see here, and this is recorded into the computer. Okay, and what's coming out? So you see, I show you just a slide of the flexion gap because of time, and then you have the dotted points, and you can filter this to a line, and then you see this is the weight of the thigh, this is the stretching of the gap and the viscoelastic range of the ligaments, and then you have a linear elastic deformity of the ligaments. So this is a kind of overstretching of the ligaments. And what you can see, this last part is the slope, indicates the stiffness of the ligaments. And if you go for a second derivation for the changing of the curve, then you can find that here is the start of the ligament deformation. So you should never go over this point. And in reality, in this patient, we had an implant thickness of 20 millimeters. And you see, this is when you go from the point we had 70 Newton on both sides, but you should never go over by about 100 newtons. But you see, so we think that we can find maybe with this technology and with these mathematical methods and so on, we can find maybe the individual stability point of this patient. And I give you just an example. So if you have, for instance, a loose extension gap, and you see, okay, it's too loose in extension, it's very important to have it fixed in extension, so I increase the poly height of 2 millimeters. And what you find out here is that you increase in flexion. You, on both sides, you know, the joint force of 60 newtons. So you will never have a good flexion. So we have done 10 patients at the very beginning of this, and you see what we could find is that the medial ligament is more stiff than the lateral, and you see here our first data about the flexion, medial, lateral, and extension, medial and lateral. What we have heard this about this really good and very critical statement of Bellemans, and he says that these stands maybe for disillusion, and I think that if you always stay with this thinking that you see navigation is just for alignment and collecting points and to find a nice mechanical axis, then you are completely right, and thank you for this. But anyway, if you think that maybe you bring in the technology to the computer, so maybe then these stands maybe for development. Thank you very much.